Hi from Northern Virginia. I'm Dr. Robert Chao, reporting for Room Now from EULAR 2021. Today, I'd like to share an oral presentation, 6885, by a Dr. Philip van de Bosch from Ghent, Belgium, on how to treat spondyloarthritis and his strategies towards early and long-term remission. I think the first question that he poses, one that we ourselves in our day-to-day practice in treating patients with spondyloarthritis, is how do you define remission in such a heterogeneous disease? I agree with his belief that the clinical concept of this disease spans beyond axial and peripheral disease. We also need to focus on other disease factors that we're aware of, such as enthesitis, dactylitis, inflammatory bowel disease, psoriasis, and uveitis. Just quickly shifting gears to dermatology for a second. I think we have a few things, fancy offices and fancy cars. Dermatologists continue to have major advancements in the treatment of psoriasis. Their psoriasis activity measures continue to be more and more stringent, and their therapies are striving and achieving PASI 100 compared to PASI 5 and PASI 50 just a few years ago. So where does rheumatology stand? And did we improve as well? Not as much. Our big therapies for psoriatic arthritis, TNF inhibitors, IL-17 inhibitors, JAK inhibitors, they're still using ASAS-40 with roughly 40 to 50% of those biologics responding in terms of ASAS-40. So some of the strategies that Dr. van de Bosch discussed on the treatment of spondyloarthritis are one, actually using an old drug. So, newer is not always better. There's some pretty good data, including ASAS partial remission with NSAIDs, showing a good majority of patients with good or excellent response in terms of treatment. The other strategy is go ahead and use the fancy new drugs. We know that between 25 to 33% of patients taking TNF inhibitors or IL-17 inhibitors or JAK inhibitors in psoriatic arthritis will reach minimal disease activity. There are some interesting head-to-head studies as well, including TNF inhibitors versus IL-17 inhibitors. They both do pretty well. We do see that IL-17 does do a little bit better, and that's possibly due to its better skin response. And focusing on enthesitis specifically, in studies, 17 inhibitor secukitamab did better than placebo, but placebo also did pretty well in terms of resolution of enthesitis. We're also seeing similar patterns in terms of IL-23 inhibitors and JAK inhibitors. So one could question, what would be the safe strategy for enthesitis? And you could say simply wait for placebo to take effect. One of the other strategies that Dr. van de Bosch poses is treat the target in tight control. And one of the studies he focuses on is the TACOPA study, which is focusing on tight control group, which is better than the standard of care group. But this comes at a price, which is typically the tight control group had more biologic use, and we know the risks and benefits of that. Another approach is the DEAR treatment approach, and DEAR stands for Dedicated, Empathic, and Educated Rheumatologist. We have to take into account the consideration and factors contributing to overall disease status. Understand that depression and anxiety are huge players in terms of disease management. We have studies that show depression and anxiety may reduce the likelihood of joint remission in rheumatoid and psoriatic arthritis patients. We also know that the depression should be managed and identified in axial spondyloarthritis patients. Another study shows that depression, anxiety, and fibromyalgia tended to cluster together to have poor health and increased axial spondyloarthritis symptoms. And again, another study focused on modifiable factors, such as, again, mental health, which predicted a non-response to TNF inhibitors in axial spondyloarthritis patients. And keep in mind, there's also some non-modifiable factors, such as social and economic factors, that should be taken into account as well. And one of the last strategies is a remission induction approach, focusing really on the CRESPA study and the ixekizumab withdrawal study. CRESPA study shows us that TNF inhibitor-induced remission was achieved in about 82% of very early peripheral spondyloarthritis patients. And out of the patients who achieved clinical remission, 57% of them achieved drug-free remission. However, 43% of them did relapse. The ixekizumab withdrawal study showed that after achieving minimal disease activity, half the ixekizumab were then receiving placebo and the other stayed on ixekizumab. However, out of the 85% who withdrew treatment, about 96% of them, or 85% flared, with 96% of them eventually re-achieving minimal disease activity after a month. We also see similar studies in axial spondyloarthritis patients, which begs us to ask, perhaps is tapering a much better strategy than discontinuing? So I think the takeaways from this talk and from this from spondyloarthritis is that we need to keep in mind that there is a wide array of disease factors in spondyloarthritis. We still have a lot of room for improvement in our treatment of arthritis. And we have to factor in modifiable and non-modifiable factors when considering treatment options or treatment response in our treatment of spondyloarthritis. So thanks for joining us today and reporting live from EULAR 2021 for Rheum. This is, again, Dr. Robert Chao, and feel free to follow me on Twitter at Dr. RBC. Thanks.